Okay, guys, I think we can go ahead and get started. My apologies for that. I am working off of my phone's hotspot, so please let me know if there are any connectivity issues, if I'm dropping out, etc. Because I'm streaming, because I'm streaming, video, etc. Um, I'm going to keep my face off. Um, that way we can save some bandwidth and hopefully not have any more connectivity issues. But thanks. We're going to do common respiratory emergencies today, and then we'll take a brief break and come back and do just some quick overview of capnography. It's not going to be a full lecture on capnography, but it makes sense to talk about capnography when we're talking about respiratory emergencies. So as usual, I don't have any disclosures. Today, we're going to talk about respiratory anatomy, some of the common respiratory conditions that we're going to encounter in EMS, along with the interventions for those. And then also, of course, we have to highlight some of the pediatric differences that sometimes will occur. So just to refresh everybody's memory, this is what your upper airway looks like. It extends basically from your lips all the way down to your vocal cords. We've got our nostrils, we've got our oral cavity. Hopefully you guys can see my cursor, but you can see here, this is the epiglottis, which is that floppy thing that gets in the way when we sometimes go to intubate. This folds down whenever we go to swallow, so that way any of the food or liquid, et cetera, goes down into your esophagus and not down into your trachea. If you remember, when we're going to intubate, if you're using a Macintosh or curved blade, you're going to want to put the tip of your um, blade here in this area called the vallecula. Okay. And then if you're using a Miller blade, you're going to be using the epiglottis itself to help lift everything forward. So the Miller blade will go in, you'll snag part of the epiglottis with it, and then as you're lifting anteriorly, that should pull everything up out of the way. You can see here we've got some of our palatine tonsils right here next to the vallecula. Up kind of at the top off to the sides would be where your adenoid tonsils are. My daughter currently is getting over a upper respiratory thing, and her tonsils, I swear, have their own gravitational pull right now. So she would be a nightmare to try and control. Then we move down into our lower airway. That basically takes off from the vocal cords all the way down until we get to the alveoli. If you notice, we have, your larynx, we've got your thyroid cartilage here, we've got your cricoid cartilage here, and then in between, we've got that cricothyroid membrane, which is very important for when we're going to do a cricothyrotomy. We then go down into the trachea. All right, the trachea then branch off into the right main stem bronchus and the left main stem bronchus, and then each of those branches off, et cetera, to control the various lobes. Your left lobe has your left lung has two lobes, this one, and you can see this one. And of course, this lower one wraps around a little bit to the back. And then your right has three lobes, as you can see here with these fissure lines. So each one of those will have a bronchus or a bronchi that goes off to the main branch. And then it's going to continue to just branch and branch and branch and branch into smaller and smaller bronchioles until we finally get down to the alveoli. Another important thing to remember is this is your diaphragm at the bottom here. This is your diaphragm. And your diaphragm, as you can see at rest, is kind of naturally curved upwards. Well, keep in mind, there's all of your organs down here below the diaphragm. And so they're constantly putting a little bit of pressure upwards. And so when your diaphragm is relaxed, i.e., not contracted or straight, it's going to naturally want to move back into this kind of curved shape. Now we get down into the alveoli. And if you remember, the alveoli are very small, basically air sacs. They look almost like grapes that expand and contract with every breath. As you can see on the outside, let me get my. As you can see on the outside here, we've got the very dense capillary membrane, et cetera. And that really is what does the majority of the work. So air comes rushing in, which expands the alveoli. They're covered in this capillary membrane that basically provides a ton of surface area for the blood, to come into contact pretty closely with the outer atmosphere. And then as it's going through there, the blood is going to suck up as much oxygen as it can onto its hemoglobin. And it's also going to get rid of any of its carbon dioxide that has built up. These alveoli form kind of these clusters, as you can see, kind of in this middle, animation, right at the end of the very small bronchioles. Um, this tissue normally is for the most part open. However, any of us at the end of this lecture who, haven't gotten up, moved around, et cetera, those alveoli at the bottom of your lungs are likely going to be compressed down a little bit. And that's okay. There's special chemicals in your mucus down here called surfactants that help to basically prevent this from getting sticky. Stickiness is going to be something we discuss a little bit more when we get into asthma, because that can cause lots of problems with getting these reinflated. Airflow is also really important when we talk about anything respiratory. Basically, at a physics level, gases and liquids are pretty similar in how they respond to various things. And so, just like we have to worry about friction loss and things like that when we're talking about fire hoses, we have to worry about the same kind of thing when it comes to our airways. Laminar flow is when the air is moving kind of essentially all in one direction. There really is not any irregularities that are causing any disruptions in the flow. It's very straight. There are no branches, etc. Transitional flow, though, is when you have laminar flow that is then having to branch off. And as that air begins to branch off, it of course is going to have some disturbance kind of in that middle area because the gas itself is trying to figure out: am I going to go left? Am I going to go right? How do I best behave? And doing so, it creates these little eddies, et cetera, like you can kind of see here. Turbulent flow is when we've got a lot of irregularities and essentially we're having a ton of friction loss, which means a ton of speed loss. So this turbulent flow is more consistent with what we would see in um, an asthmatic or COPD, or where we've got mucus that's plugging things up, we've got swelling, et cetera. And so there's all these irregularities that are kind of disrupting the flow as it goes through. So less gas is able to freely flow. Now, granted, at a very small level, any of the airways that we have on a good day are going to have turbulence. It's a matter of the degree of turbulence. We want to try and get our airways open enough that we approach this laminar flow kind of state. But of course, the bronchus itself is irregular and covered in mucus on a normal basis as well. So it's not completely laminar. So let's talk briefly about how our lungs expand. So the main things that drive our exchange of gas is our diaphragm. So what happens is our diaphragm is going to contract, and as you can see, it's kind of in a curved state here. And as it contracts, it gets shorter. Well, that flattens out, so that all of a sudden creates this relative negative pressure within the chest cavity. Now, one thing that I was taught in high school is that nature doesn't suck. So nature does not actually really produce vacuums, et cetera. Instead, it goes from higher pressure to lower pressure. And so it really is, nature is more blowing. And what happens is you have this relative negative pressure in the chest cavity, which then causes you to be a lower pressure than the outside environment. And so what happens is the gases, et cetera, want to naturally move into that lower pressure environment to equalize the pressures out. So as that happens, our lungs expand, they get bigger, et cetera. Then as we go to release and relax, we're now going to have exhalation. So our abdominal organs are going to be pushing up towards the chest cavity. We've got the outside environment that is also now pushing from the outside. And what happens is that forms a relative positive pressure within the chest. And so again, nature wants to equalize those differences. And so the air is going to rush from inside our lungs back out to the environment and go forth from there. Some of the other muscles that are involved are your intercostals and your scalenes, et cetera. Those are all trying to help us generate these forces needed to move the gas. But we don't really rely on them unless we are getting to a really bad part of an asthma exacerbation or a COPD exacerbation. So let's pivot now that we know some of the basic physiology into some of the respiratory conditions. Obviously, we're not going to go through in detail every single one of the respiratory emergencies that can happen out there. I really wanted to focus on the ones that we are most likely to encounter, um, and that have similar treatments. So let's talk about asthma. So asthma is an interesting thing that in most people sets in childhood, and essentially their airway is hyperreactive. Any kind of irritation to it is going to cause this, typically pretty decent response, and that could be as little as smoke, dust, allergens, chemicals. Cold will sometimes induce it in people. Smoking cigarettes, of course, will make this worse. But anything that irritates your airway has the propensity to, start one of these asthma exacerbations. And you've kind of got three different things that are occurring when asthma kicks in. So you have kind of this, hyper immune response where the mucous membranes themselves begin to get very inflamed and irritated and swollen. You also then begin to get mucus production that is rather significant, along with muscle spasms. You've got these smooth muscles that surround your bronchioles, and those, when they get irritated, spasm down. So you have, basically a pipe that is getting thicker. The pipe is getting filled with mucus and is also getting smaller because of the smooth muscle contractions. So this gives you an idea of why we tend to have more problems with this in kids. So a lot of us will have heard of people who, you know, developed um, asthma as a kid and then they quote outgrew it unquote. Well, the reality is, it's just their airway got bigger. So if we look here on the left, we've got an infant with a 4 millimeter inner diameter airway. And when we have 1 millimeter of swelling set up, we've now increased the resistance of that pipe now by 16 times and reduced the cross-sectional area by 75%. Whereas if we take an adult who maybe has an 8 millimeter wide airway and we put the same 1 millimeter of inflammation in there, we've only increased that resistance by 3 times. And we've only reduced the cross-sectional diameter by about 45%. And so this is why kids will outgrow it, is literally their airway just simply gets bigger. The amount of swelling is still the same, the amount of mucus production is still the same, the amount of small muscle contraction is still the same. It really is, the airway has gotten bigger. We oftentimes will not label a kid less than 2 as having had true asthma. Instead, we'll just call it reactive airway disease, because a lot of kids, by the time they are, 2, et cetera, their airway has grown enough that the consequence of this irritation, et cetera, has lessened enough that they really don't have problems. So even though somebody may have, outgrown their asthma, they're still getting the same reaction. It's just it's no longer clinically relevant. They're no longer having difficulties with gas exchange. So our asthma treatment is, going to target these three different ways that our body reacts to these irritants, and it's really important that we intervene before respiratory failure. So of course, we want to support their oxygenation, but a lot of the time with asthmatics, their problem is not oxygen; it's gas exchange. So we can put somebody on 100% oxygen, but if we're still not getting any gas exchange, that's a big problem. So we want to start by giving them some of the breathing treatments that we typically use. We use albuterol because it relaxes those smooth muscles that wrap around the bronchioles, so we get those to relax. We use ipratropium because that decreases that mucus production, and so we get less gunk in our airway. And frequently, once we've done both of those, you're going to have patients start to cough, and you may even have their wheezing apparently get worse. If somebody is really, really tight, it takes a bit, for that airflow to wheeze. You've got to have enough volume of air moving to get that whistling effect. And so, as we open that airway up with the breathing treatments, we now are getting enough air movement that we can start to hear that whistle. And so, even though somebody may, quote, sound worse, they're actually probably better. They probably were diminished or absent to begin with, which is why you didn't hear any wheezing. And then as you've opened them up, enough gas is now exchanging that you're able to hear things. We then also want to add in steroids. The couple that we carry are methylprednisolone or solumedrol or prednisone. The reason we give a steroid is because that decreases this inflammatory response that is occurring. So we get that swelling that's present to begin to go down as well. Very important thing to note is methylprednisolone is supposed to be given either intravenously or orally. Even though it's an IV solution, we don't want it being given intramuscular. And the reason for that is it's alcohol based, so hurts like heck, and also is not very well absorbed through the soft tissue. And so it's going to take them quite a while to begin to get any benefit from it. Whereas if we give it to them by mouth, they're going to get significant benefit from it very quickly. The only place in our protocol where you will find solumedrol as an intramuscular injection is in the adrenal crisis protocol. And that's because even the smallest amount of steroids in those people can have profound benefits to them. And so, if you're unable to get access and someone is having an adrenal crisis, you can give them intramuscular solumedrol if they're unable to drink it. CPAP and BiPAP can also be very helpful. As we talked about earlier, our lungs have surfactant, et cetera, that helps keep those alveoli from sticking to one another. But when we're having an asthma or COPD exacerbation, we have so much mucus being produced that it kind of washes away some of that surfactant and makes it less effective. By putting someone on CPAP or BiPAP, we're not only improving the pressure, gradients, et cetera, but we also are, keeping some of these alveoli popped open and not collapsed down, so they don't have that chance to kind of stick to one another. If somebody is absolutely crashing in front of you, you can give them intramuscular epinephrine. In the majority of kind of the third world, they don't have nebulizers. They don't have electricity to power a nebulizer. They don't have access to oxygen powered devices and things like that. And so they can't really give nebulizer treatments. They may be lucky if they have meter dose inhalers of this stuff, but in a lot of places they don't. They have epinephrine. Epinephrine is cheap, very effective, has a great shelf life, etc. Epinephrine is going to cause some of the very same effects. So if you have kind of thrown the kitchen sink at somebody and they are still dwindling in front of you, intramuscular epinephrine, maybe you're saving grace. So go ahead and give them an intramuscular dose of epinephrine. So let's talk briefly about CPAP since we just mentioned it. It stands for continuous positive airway pressure. We are starting to see some EMS agencies carrying BiPAP or bi-level continuous airway pressure. BiPAP is a little more sophisticated and requires a more advanced machine because essentially the machine is able to sense when you're inhaling and also when you're getting ready to exhale, and it provides a higher pressure when you are inhaling to help get that oxygen and stuff into your lungs. But then when it senses that you're done inhaling, it drops to a lower pressure to make exhalation a little bit easier. It can be more readily tolerated because it doesn't feel as weird as plain CPAP does. It does have benefits, et cetera. It's a lot more complicated. Most EMS agencies are going to only be carrying CPAP, which is honestly plenty effective. So CPAP has some cardiovascular effects as well. It helps to reduce preload and afterload, making it easier for the heart to pump. It helps to open the airway, as we said. It keeps those alveoli kind of propped open. And there is theory that when we've got thinner fluids such as CHF or pulmonary edema, it helps to spread that fluid more evenly over the membrane, so that way it's easier for gases to exchange across it. So the indications that we have in our protocol are they have to be an adult, and the reason they have to be an adult is because we don't carry pediatric sizes. I would venture to say that probably the children's mobile ICU team and the helicopters are probably the only places that carry pediatric CPAP or BiPAP. They've got to be awake and oriented enough that they can follow your instructions and can voice concerns and keep their airway clean, et cetera. They've got to maintain that open airway on their own. They can't have, a nasal trumpet or an oral airway in place to use this. And they also need to have a systolic blood pressure of greater than 90. And the reason for that is if they're hypotensive, this can cause in some people a little bit of a drop in blood pressure. So we need to be mindful that the person's got enough blood pressure to begin with. The contraindications listed are, of course, respiratory arrest. This is not like bag valve mask ventilation. It has to be driven by the patient. If you have a suspected pneumothorax, obviously putting high pressure on that airway is not ideal. And so if you have a suspected pneumothorax, you probably should not have them on CPAP or BiPAP. If they have a tracheostomy, you want to be using the trach. You shouldn't be using the oropharynx for your gas exchange. If the patient's at risk of aspiration, that's a very big problem. If you can imagine throwing up in a CPAP mask and then having that same CPAP shove that vomit right back at you when you go to take an inhalation is bad. And so these patients are going to have really bad outcomes if they aspirate, or if the patient's intubated. For us in the field, if the patient's intubated, we need to either have them on a vent, or we need to have them being bagged actively. At the hospital, we will sometimes put intubated patients on CPAP or BiPAP, but that is in the process of essentially weaning them off of the ventilator. So we begin to wake them up. We get them oriented enough that they can follow some of our commands, et cetera. And we begin to basically shut the ventilator back so that it's more relying on that patient, taking those deep breaths, effectively becoming CPAP or BiPAP. So the physical exam findings that we have to put this on is they've got to have some sort of an acute respiratory distress issue. Okay. And then the other inclusion criteria is they have to have two or more of the following of this, which is they've got to be tachypnic, have retractions, accessory muscle use, or fatigue, a pulse ox of less than 94% at any time. Their lung exam can have wheezing, rowels, be diminished, and they have to have respiratory failure of any etiology. So if you think about it, really, a lot of our COPDers and asthmatics are going to meet this inclusion criteria just with a mild exacerbation. And we kind of wrote this intentionally because it is far better for you to put someone on CPAP that doesn't need it than it is for you to withhold the CPAP and have that person get significantly worse. So please, if your antenna go up and you're thinking that you need to put this person on CPAP or BiPAP, you do. Go ahead and put them on it. So to apply it, we want to make sure again that we're putting it on early and often. We don't want this person to progress to the point where they now have, frank respiratory failure. Of course, we want to make sure that they're on monitoring and that we've got pulse ox. You can put them on end-tidal capnography. You just have to make sure that you put the nasal cannula capno on before you put the face mask on. That allows you to get a pretty accurate end-tidal capnography despite there being CPAP. Of course, we want to explain the procedure. When I explain this to patients, I tell them it's going to feel weird. I try and describe that it's kind of like when you were a kid and you'd stick your head out the window as your parents were on the highway, and you get that rush of air, and it almost feels weird, like you can't breathe. It's that similar kind of feeling. And I say, I want you to give me a couple minutes. Give me 2 minutes on this. And if in 2 to 3 minutes you're still feeling like you're suffocating, et cetera, we'll take it off. You're not going to tolerate it. But I want you to give me 2 or 3 minutes. And usually, what I'll do is at this point, we're getting the person onto the CPAP, and I basically start to ramble. I start to ramble about, you know, what's going on with them, what to expect when they get to the hospital, that kind of thing, and try and really kind of distract them from what they're going through. So, get the person to hopefully calm down and get distracted enough. And by the time those 2 or 3 minutes are up, a lot of the time they have forgotten that it's even there, that it's even a problem. So that's one thing I've had a lot of success with. Of course, you want to make sure, since most of our devices are oxygen powered, that we've got enough oxygen to adequately start the CPAP and keep them on it. We also need to have a backup plan. If they are not able to tolerate the CPAP or BiPAP, what are you going to do next? Is it you're going to try intramuscular epinephrine? Is it you're going to assist their ventilations with bag valve mask? But whatever your backup plan is, make sure you have it before you need it. Of course, we then, place the mask, check it for air leaks. Again, if we've got the end-tidal nasal prongs on, we are going to have likely a little bit of leakage around where the nasal piece kind of enters the mask. That's okay. We're just looking for big air leaks. Coach the patient, as I said earlier, that tends to work pretty effectively. But if it's not, you are able to do Versed 1 to 2 milligrams every 5 minutes to a max of 5 milligrams. The reason we have relatively low dose here is, if you remember, Versed, just like all benzodiazepines, has a certain amount of respiratory depression. And this is somebody that we really don't want to have their respiratory drive, dialed back. So we need to be slow. It's just enough to kind of take the edge off, but we don't want them goofy, etc. It's very important that once you start someone on CPAP or BiPAP, that you leave them on that CPAP or BiPAP, assuming that they're not having, complications, until you're ready to switch them over to the hospital equipment. And the reason for that is every break that we take with the CPAP or BiPAP means that those alveoli that we've propped back open, that previously weren't able to be used, those are going to immediately collapse and stick to each other. And we're going to basically be starting off not quite from zero, but we're going to be starting off from a much lower place than where we currently were. So it's very important to minimize the breaks that you have, um, between the or between us and the hospital. All right, so let's pivot. So COPD is very similar to asthma, but this is a chronic disease, and it leads to destruction of the lung tissue. Essentially, we have chronic bronchoconstriction and inflammation and mucus production, et cetera. And as a result of all this, air is not able to exchange as easily. Um, that lack of airflow, et cetera, means that some of these alveoli are going to get plugged up completely with mucus. As a result of this, as time goes by, if that area does not have airflow kind of restored to it, it's going to begin to break down those alveolar sacs, and we eventually will form these cavities called blebs, which are basically like these balloons within the lung tissue itself. They really don't do any gas exchange. They can be rather sizable. All they do is really take up space, and the tissue is not necessarily normal. So these are also a common place where patients with advanced COPD may get an air leak. They may develop a pneumothorax because one of these blebs may rupture and leak air into their chest cavity. The treatment that we do, from an EMS standpoint, is nearly the same as what we do for asthmatics because it's the same kinds of things that are occurring. This tends to be more of a slow progression where their exacerbation gets worse over a few hours to a few days, whereas asthma attacks really can happen in a matter of a couple of minutes. Same as with asthma, CPAP, BiPAP can be very beneficial, but again, because of these potential blebs, we want to make sure that we're watching for pneumothorax. And if we see one, we take them off. And if it becomes tension, we need to then decompress it. Choking. So the Heimlich maneuver is the mainstay of treatment. We're very fortunate that Dr. Heimlich, came up with this idea. He is a Cincinnatian. My one of my best friends from high school actually lived across the street from, I believe it was his daughter and granddaughter. Only met them very briefly. Never met Dr. Heimlich though. Um, but the Heimlich maneuver, kind of really took choking from, a virtual death sentence to something that's easily survivable now. Back blows are acceptable for infants. If the person becomes unresponsive, we're going to be basically doing CPR, chest thrusts, to hopefully dislodge whatever that is. If you're a paramedic, you can attempt, if they are unresponsive, to visualize the airway with a laryngoscope. And if you can see something, you may, use your McGills to grab it and pull it out. Sometimes you can't do that. You can't actually see anything in there. So if this person is unresponsive and you want to attempt to intubate them, I think that's totally fine. You can try intubating with a bougie. And the reason I say with a bougie is because that bougie is supposed to pass basically down to the carina. And in passing that bougie down to the carina, we may dislodge whatever is in that trachea enough that we can now get, airflow. Or we may shove it down far enough where it's only plugging up half of the chest. So maybe plugging the right main stem bronchus. And so we're still able to ventilate through the left. A cricothyrotomy can sometimes be life-saving, especially if they have something stuck right at their vocal cords because the cricothyroid membrane is just below that. So again, nobody should die of respiratory arrest, who doesn't have their neck cut on. All right, so let's talk about acute pulmonary edema. Um, and we're not necessarily talking about all acute pulmonary edema, but really this is more of the catecholamine mediated acute pulmonary edema. I thought about using Harambe, wasn't sure if it was too early. And yeah, I know he's a gorilla. He's not an ape. But I couldn't resist the, you know, putting a monkey in. So with catecholamine acute pulmonary edema, the myocardium is not able to provide enough blood flow to meet the demand. So we have a demand for, a given amount, and we're pumping as hard as we can, and we're not able to meet that demand. And so what happens is, fluids begin to back up and build up. So we then get pulmonary and vascular congestion that's occurring. And this can be caused by a variety of things. It could be myocardial injury, it could be a STEMI or a non-STEMI, it could be cardiomyopathy, it could be that they have a valve emergency, where one of their chordae tendineae ruptured, and so they all of a sudden go from having a functional valve to, a non-functional valve. This also, as we get older, can sometimes be because of increasing stiffness of the heart. Cardiac compliance becomes the issue, and so if the heart is stiff, it's not able to fill up as much. So this decreased cardiac output, becomes problematic, and our body, again, is not having its needs met, and so it begins to dump all kinds of chemicals into your system, trying to hopefully improve this. So we have this decreased cardiac output that then causes us to dump epinephrine into the system to kind of get the heart rate to speed up. But unfortunately, it also has the side effect of clamping down somewhat on our arteries, which then increases their systemic vascular resistance. So our body is attempting to, maintain perfusion by clamping down, which means that the heart now has to push even harder when it wasn't already able to meet that demand, which further decreases their cardiac output, which causes them to release more epinephrine. And you see this downward spiral until they really are not able to, um, maintain things at all, and they crash. Um, so we need to intervene, hopefully, before they get to the point of that crash. So when we're taking a look at these folks, we want to, kind of figure out, are they sick or not sick? Very quickly listen to their lung sounds. They may have rales in their bases. Um, we want to assess their work of breathing, get a set of vital signs, and very frequently with these catecholamine associated pulmonary edema events, we will see blood pressure sometimes as high as in the 300s over mid 100s. And that's just to show you like how hard it is for that heart to pump, and the kind of clamping down that can occur. Determine our need for CPAP. Again, this can be extremely beneficial. Get a 12 lead. We need to make sure this person isn't in cardiogenic shock, and having, a STEMI or a non-STEMI. Get an IV in these folks. And then, as you're doing all of this, you need to determine their need for medications. So our exam may show JVD, rales. There may be diminished or absent breath sounds if they've gotten that full. Some of them may have peripheral edema. However, because these are relatively rapid onset, we won't always see pulmonary edema. We may see that with an acute CHF exacerbation that has a component of pulmonary edema, but it's a different phenomenon than these acute events. They probably are going to be tachypnic. They're going to have signs of poor perfusion. They may be confused. They may have mottling. They may even be cyanotic. And they may be hypoxic because they're not able to, adequately oxygenate because of the fluid in their lungs. So we've all learned it's pulmonary edema. Well, that's a fluid problem, right? So we should give Lasix, right? Well, no, it's not a fluid problem. It's a pump problem. Lasix is going to cause you to, pee out some excess fluids. But this person may actually be relatively dehydrated. They may be, dry, and the Lasix is not going to help. We also know that from some studies that were done both in EMS and in the emergency department, that all of us are horrible at determining based on physical exam alone whether this is a CHF exacerbation or pneumonia. It's literally a coin toss, 50-50. So if we have somebody that we, miscategorize, and we think they're having CHF or pulmonary edema, when the reality is they actually have pneumonia, if we give that person Lasix, we're in a world of hurt. That person may be on the verge of getting septic, and so they need the fluids. In addition, getting somebody with pneumonia dehydrated is not a good idea. On the other hand, nitrates are very short acting. If we think somebody is having a CHF exacerbation, but they actually have pneumonia, and we give them nitrates, and it doesn't turn out to be, CHF, it's instead pneumonia, we just turn the nitrates off. And within a couple of minutes, literally, that nitroglycerin has exited their system and they're back to where they were without having any fluid loss. Lots of people will say, but doc, as soon as we give the nitrates or the Lasix, they start to pee like crazy. And yeah, you're right. But the Lasix isn't really the main mediator of that. It tends to be more of the nitrates. In addition to clamping down, all of your extremities, et cetera, the epinephrine is clamping down every artery, including your renal arteries. So as we begin to give them the nitroglycerin, it begins to dilate that renal artery open again, and we get better perfusion through the kidney. And the kidney does what the kidney does, which is it filters. And so if it's getting more blood flow, it's going to filter more. And so all of a sudden they will get these diuretic events. And it really is not because of any Lasix that they've been given, but it's more because of the increased blood flow to the kidneys. So the way nitrates work is it dilates the veins via the nitric oxide pathway, and eventually begins to dilate the arteries as well. So this basically begins to break that cycle of further clamping down, raising the pressures, et cetera. It reduces the preload and their afterload, so it becomes easier and easier for the heart to not only fill but to pump. That in turn improves cardiac output. It's important, though, before we start giving nitrates, that we make sure the patient has not taken one of the phosphodiesterase inhibitors, such as Viagra or Cialis. Those medications work very similarly with the nitric oxide pathway. They prevent the breakdown, and so the nitrates are able to stick around much longer than normal. And so even small doses of nitrates when someone is taking these medications can lead to pretty significant blood pressure changes. So in our protocol, if we've got somebody with mild symptoms, we're going to begin administering low dose sublingual nitro. So we're talking zero point 0.4 milligrams every 3 to 5 minutes times three. Um, Again, if we've got somebody on CPAP or BiPAP, we don't necessarily want to take that mask off to slip another nitroglycerin under their tongue. Okay. If we've got moderate to severe symptoms, we're going to begin administering higher doses of sublingual nitroglycerin. So we're talking zero point 0.8 milligrams, so 2 tablets, potentially even 1.2 milligrams, or 3 tablets every 3 to 5 minutes times three. Um, a lot of people get freaked out when we start talking about more than one sublingual nitroglycerin, because nitroglycerin can cause your blood pressure to drop. Again, if we've got somebody whose blood pressure is in the 300s or approaching the 300s, that extra nitroglycerin is absolutely needed. That heart is not able to pump with those high pressures, and so we need to get those pressures pretty rapidly lowered. A little bit of napkin math. So zero point 0.4 milligrams is equal to 400 micrograms. All right. If we divide that 400 micrograms out by, say, every 5 minutes, okay, that equates out to um, roughly 80 micrograms of nitroglycerin per minute. Well, that is where we will start patients in the emergency department on that are having this when we put them on a nitroglycerin drip. And we sometimes will go as high as 250 micrograms per minute in a nitroglycerin drip. So yes, for us in EMS, we don't encounter these kinds of nitroglycerin doses very often. But I'm telling you, in the right patient, it is safe. We do it on a routine basis in the emergency department and in the cardiac ICU. It's just a matter of getting more comfortable with it. Some places also will carry topical nitroglycerin that we can use instead of low dose nitroglycerin. So if they have a systolic blood pressure of 100 to 115, we can give them an inch, 2 inches if it's greater than 200. Before putting nitroglycerin on or under the tongue, we want to make sure that they're not having an inferior MI. Inferior MI, as we know, is very dependent on blood pressure. And so if we suddenly dilate everything and drop their blood pressures, that causes significant problems. After every dose of nitroglycerin, prior to the next dose, we want to make sure that we're reassessing that blood pressure to see what kind of a response we've gotten. Most of the time, we're going to see some positive movement. It may be, though, that we need to give additional or even potentially a higher dose. So pressors in these catecholamine-mediated acute pulmonary edema events, you sometimes have to give push-dose epinephrine. If somebody's blood pressure is low, despite them having a ton of kind of their own catecholamines surging around, we need to do something to get that cardiac output to improve. So even though part of the problem is too much of the epinephrine circulating around, we need to get that blood pressure up somehow. And so by clamping down a little bit more and getting better perfusion, hopefully through the coronary arteries, we can then improve the cardiac output and kind of get out of this downward spiral. There are times when we're potentially going to have somebody on, pressors and nitrate therapy, simply because we're targeting different things with the various different medications. So hopefully by improving their blood pressure, that improves their coronary blood flow, which means the heart now has the fuel it needs to be able to contract even stronger. So let's talk about CHF. So CHF may have components of pulmonary edema associated with it, but CHF tends to be a slower progressing thing. They typically will begin to have peripheral edema because the fluid is slowly backing up. They may have weight gain. One of the best ways that we have for trending how somebody is doing with their CHF management is by having them do daily scales. And if they go up by a certain amount, they take this amount of extra Lasix, et cetera. The CPAP and nitrates can still be beneficial, especially if the blood pressure is elevated. That can still be very beneficial. But again, as we talked about, diuretics like Lasix cause more harm in EMS than benefit, according to the best literature we've got. And frankly, in the emergency department, my opinion is you really ought to have a pretty slam dunk diagnosis of CHF or acute pulmonary edema before giving them a diuretic, because those diuretics are going to be sticking around for a while. All right, so let's talk quickly about trauma. Obviously, any kind of chest trauma can cause damage to any of the underlying organs. It can cause a pneumothorax, hemothorax, pneumohemothorax. Sometimes patients will get a diaphragm rupture, which is horrible, where your intestine or your liver ends up partially in your chest cavity, makes for a rough afternoon for the trauma surgeon. In really bad cases, sometimes patients will develop a tracheal rupture, or they'll shear off one of their main stem bronchi, causing massive pneumothorax. It's very important that we recognize attention pneumothorax, as it's occurring. These patients will have progressive and sometimes very rapid respiratory distress. Their trachea may begin to deviate, away from the side that's affected. They may develop JVD. Their blood pressure may begin to go down as that pneumothorax becomes higher and higher pressurized. It'll impact the ability of the heart to both fill and contract. And they may also have subcutaneous emphysema. Subcutaneous emphysema is just these little air pockets that will form under the skin. If you've never felt it, it feels very similar to popping bubble wrap, or like having Rice Krispie, cereal underneath a piece of cloth, where you can feel kind of this popping and crunching, etc. And is really, frankly, a very weird sensation. But they may develop enough of a leak that the gases, etc., are now getting into the subcutaneous tissues. This is an example of a pneumothorax. As you can see in the diagram, the cartoon on the right, our lung is no longer filling up the entire chest cavity, and so we've got this empty space kind of all around the lung that you know is beginning to put pressure on that lung. The X-ray that is on the left-hand side, if you look over here on the right, we can see kind of all this haze. Okay, all of that haziness is your normal lung tissue. But if you look over here, you don't really have any of that haziness. Frankly, you've got this nice, clear, black, background, and that's because there's no lung tissue there. It's air. Our lung is collapsed down all the way over here. So we've got this chest cavity mostly full of air. We also can see that this is actually a tension pneumothorax because our trachea is deviated off to this right side. So this is definitely under pressure. This definitely needs a needle placed in it. So when we're getting ready to do a needle thoracostomy to decompress this, we've got basically two choices. We've got the anterior approach and then more of the lateral approach. If we're going to do the lateral approach, it's going to be between the seventh and eighth ribs, or roughly at about the nipple line, at an anterior axillary line. So kind of at the front of the armpit is where we want to stick that needle. In an ideal situation, you will have a proper, you know, needle thoracostomy catheter. You can, in some patients, try with a 14 or a 16 gauge, but oftentimes, it's just simply not going to be thick enough to get through the multiple layers that are currently present, and so you may never actually reach the pocket of gas. If we're going to do the anterior approach, we go at a mid-clavicular line between the second and third intercostal space. And again, same concept. We're going to advance that needle in until we get a pop and a hiss, and then slowly thread the catheter down over that needle. And then you want to leave it in place. You can, make a butterfly valve type of thing. Honestly, I've seen a lot of people will just simply put a stopcock, on the end of it. And what they'll do is they'll periodically, kind of burp the stopcock in case pressure begins to build up again. But really, unless you're using one of the needle thoracostomy devices, that angiocath is flimsy enough that it probably is going to get collapsed down, just simply by the, muscle tissue and subcutaneous tissue. Anaphylaxis. Anaphylaxis causes obstructions of both the upper and lower airways. So we can get angioedema from, your lips, and that can carry all the way down into your larynx and into your trachea. Um, in addition to getting the swelling, we get, again, a lot of mucus membrane secretions, and sometimes we get that spasming of the airways, just like we do with asthma. This is typically caused by exposure to an allergen with basically this overdone response to that allergen. Believe it or not, epinephrine is the cornerstone of treatment. Steroids may benefit, in a more longer term process, but they really are not going to have any effectiveness right away. Benadryl really is only useful in standard allergies. So Benadryl blocks histamine, and histamine is only one of the many, chemicals that our body is putting out to have this inflammation kind of set in. And so, if we're only blocking one of them, the cascade is still occurring. So we're still going to get swelling, et cetera. And Benadryl takes a while to kick in. It's not super fast acting. So by the time that Benadryl begins to kick in, this person may be long dead because we've lost their airway. So be prepared for airway control. Again, this angioedema can set in very, very rapidly. And so if you begin to see, lip or um, tongue swelling, or they sound like their voice is kind of muffled, et cetera, that's an impending airway collapse. And so you need to be aggressively managing that airway, and calling ahead to the emergency department to let them know that if this person is still awake when we get there, they're probably going to need to get put down and get their airway controlled before we have so much swelling that we simply can't get a tube in. This is an example of what angioedema will look like. This is not an anaphylaxis angioedema, but as you can see here, the right side of this guy's tongue is swollen, and it's extremely thick. So with anaphylaxis, you'd expect to see that entire tongue to be swollen and very thick, along with potentially the lips, and as we go further back, other parts of the upper airway. In this case, this gentleman probably has either one of the hereditary causes of angioedema, or this may be from an ACE inhibitor or a blood pressure medication that is known to cause angioedema. Pneumonia. So pneumonia can be caused by a variety of different things. Most common that causes problems in adults is going to be bacterial pneumonia. Pneumonitis is very similar, but is more from chemical burning, whether that be stomach acid because you aspirate, or because of an inhaled toxic gas. When we are dealing with somebody who's, potentially has pneumonia, we need to screen for and aggressively treat their sepsis. Patients with pneumonia can get septic, and it can create all kinds of problems. Some of these folks are going to require supplemental oxygen because enough of their lung tissue is infected that it may not have enough reserve to adequately keep the body oxygenated. They may require CPAP or BiPAP. Again, if they're having to struggle to breathe, this may make it easier for them to breathe, and it may also help spread some of that pus out over the mucous membrane more readily. Again, the bacteria, the virus, the fungus, et cetera, they're irritating to the tissue. And so we may still get, that smooth muscle spasming of the airway. And so albuterol in some patients really can help. I've also found that honestly, some of the time it's more the saline that the albuterol is dissolved within that I think may have the bigger effect than the albuterol itself. Just simply getting a nice cool mist in there helps to thin out those mucus secretions, et cetera, and allow that patient to hopefully begin to cough some of this stuff up. Toxins. So I wanted to kind of wrap this up with ensuring that we don't lose sight of the fact that not everything that causes shortness of breath is respiratory. Someone may complain of severe shortness of breath, and it may actually be that they have something else going on, such as a STEMI or one of these toxin ingestions, cyanide poisoning, methemoglobinemia, other irritant gases, carbon monoxide. These are all going to have the same kinds of presentations where the patient is short of breath, feels like they're short of breath. In a couple of these cases, they may even have a completely normal um, pulse ox. But the problem is that it's either falsely elevated, or the problem isn't with the oxygen, it's with the use of the oxygen, as in the case of cyanide. So these patients may need supplemental oxygen, especially if we've got a suspected carbon monoxide poisoning. We need to get them on high flow oxygen, even though their pulse ox may be normal, because that high flow oxygen is going to help to essentially shove that carbon monoxide off of the hemoglobin and allow the oxygen to connect again. And then there's, obviously toxin-specific treatment such as the cyanokits. So if someone is having cyanide poisoning, we want to try and aggressively get them cyanokit. All right, it is 10:10. Let's take a quick 10-minute break, and we'll be back at 10:20 to wrap out with a little bit of end-tidal capnography. So see everybody in about 10 minutes. All right, folks. We'll wrap up here with just a quick overview of capnography again. So again, just to refresh everybody's memory, this is kind of a diagram of the alveolar sac. We see that capillary membrane that has the blood circulating throughout it. The blood is, of course, releasing the CO2 into the alveolar space, and at the same time, it's absorbing the oxygen that's in that alveolar space. And when we talk about end-tidal capnography, we're talking about respiration and perfusion. We're not talking about oxygenation. Pulse oximetry tells us about oxygenation. End-tidal capnography is trying to measure as close as possible to that capillary membrane what the amount of CO2 is. And that tells us about not only how that gas is being exchanged, but to what extent. So it can tell us about how their airway is, but it can also tell us about how good their perfusion is. So again, the pulse ox tells us about the oxygen. The capnography is going to tell us about that carbon dioxide. So our normal values of carbon dioxide are 35 to 45 millimeters of mercury. If we're not breathing adequately, that number is going to go up. It's not like a pulse ox where, if we stop breathing, our pulse ox slowly goes down. With this, if we stop breathing, our capnography goes up because that CO2 is just building and building and building and not able to actually get exchanged. Conversely, if we're hyperventilating, it's going to get lower than that. It's going to go below 35 millimeters of mercury. Some bad COPDers will become what are called CO2 retainers. They constantly have this COPD kind of acting up and are not able to adequately exchange the gas. So as a result, end up kind of having the carbon dioxide level build up. Their body, makes adjustments for it. This doesn't happen, overnight, but they will make adjustments for it. The end tidal numbers that we get are not actually the gas that's right there at the capillary membrane. It's as close as we can get to that. And so the end tidal numbers that we get are usually about 5 millimeters of mercury lower than the actual blood gas. So if we were to take a sample of blood, the amount of carbon dioxide that's physically in that blood is likely going to be slightly higher by about 5 points. So again, with ventilation, we've got two detectors in our body. One is pH dependent, which tells us about the carbon dioxide level. Because remember, carbon dioxide, when it is dissolved in water, is carbonic acid. And so that's one of the things that gives soda its kind of tanginess is that carbonic acid. The other detector is oxygen dependent. And so the capnography is going to tell us about their ventilation, and is not going to tell us about that oxygen dependent detector. Um, Anybody who's seen the full on lecture of this knows that one of the things I talk about is if we were to put somebody on 100% oxygen, non-rebreather, truly 100%, for 10 minutes, wash out all the nitrogen that's in our system and such, and really saturate every molecule of that hemoglobin, and then we paralyze that person, they're not going to get hypoxic for quite a bit. But what is going to happen is they're going to become extremely acidotic because that carbon dioxide is going to continue to build in their system and begin to cause problems way sooner than any hypoxia. So there are a bunch of different methods of detecting carbon dioxide. We're just going to blow through those really quick. So colorimetric used to be the most common one, primarily only able to be used for endotracheally intubated patients. Capnometry was then kind of one of the first digital versions where it's basically only telling you a number. So it tells you what that final number is. In this particular instance, this device also is able to count the respirations per minute. These are still useful if you're going to confirm tube placement, but capnography, where there's a graph associated with it, has become so ubiquitous that it's rare to see these anymore. There's a couple of different methods of detecting the carbon dioxide. Side stream is what is most commonly used. Side stream has the benefit of being able to be used by nasal cannula, and the sensor is able to be protected much more robustly. If you think about it, we need to have stuff that's firefighter proof, and having a sensor that is freely floating out without a bunch of protection around it means it's not firefighter proof. You drop one of those and you're out $3,000 just to get a new sensor and cabling. Whereas by having side stream, the detector itself is actually housed back within the monitor, and a small suction is applied to the tubing that sucks a little bit of the air out of that column of gas and sends it all the way back to the sensor where it does its actual detecting. And this is that kind of mainstream or inline that I was referring to. If you see here, the sensor, it's basically just an infrared light sensor, is relatively small, but it's got a stick on the end of an endotracheal tube, and so it can't be super well protected. These are becoming less and less common because of all the problems associated with them being dropped or the cables breaking and things like that. It's much better to replace a cheap plastic catheter than it is to try and replace one of these. So once we, get the person on capnography, it's very important that we understand what we're seeing. And so when we look at a capnograph, we're looking at every exhalation. This is not inhalations. This is exhalations. This is the carbon dioxide as we exhale is rising. All right. The shape of the waveform can tell us a lot, along with what that number, that final number, correlates to. So as we talked about, there's a ton of dead space. The alveolus is really the only thing that's doing any meaningful gas exchange. And so all the rest of that tubing, that white stuff that you see on the left-hand side of that lung, that's all dead space. So we have to clear that column of dead air out of the area before we kind of are getting down to that alveolar area. And so as we exhale, that initial huge bump in carbon dioxide that starts that kind of hump, that is that dead space, kind of clearing out of the way. So we begin to, exhale. We're beginning to get that dead space gas mixing with the alveolar space. But then once we begin to plateau out, we're getting more into the alveolar gas. And then right as we get to the end, that's as close as we can get to being right next to that capillary membrane, as possible. So that number is that end tidal number. And then we inhale. And as we inhale, our carbon dioxide level drops rather rapidly. So again, this is that kind of demonstration of there's a difference between that end tidal capnography number and what the membrane or what the bloodstream actually has. So there is a little bit of a gap there, but it's really not of any significance. So when we're looking at these waves, we need to identify the height of the waveform along with its with the corresponding number, but we also need to look at the shape of the waveform. So this is our normal waveform that we've been looking at. It has nice smooth edges. The height looks pretty good. It's a nice controlled exhalation, and then we get an inhalation, and the next exhalation then occurs. When we're hyperventilating, we're going to see that these plateaus are getting smaller and smaller and smaller. And if you look, over here, our number is getting lower and lower and lower. And that means that this person is hyperventilating. So we either need to try and coach this person to slow their breathing down, or if we happen to be bagging them, we're bagging them too rapidly or with too much volume. And so we need to slow down or have, less volume with each bag. It's really important that, especially our EMTs, understand this because very frequently the EMTs are given that kind of responsibility of bagging the patient. And this is a way that an EMT can very effectively understand how good they're doing with their bagging. They want to keep that number between 35 and 45. And as long as they're doing that, then we should be adequate. Conversely, if we're not ventilating them enough, our peaks are going to get higher and higher and higher. And as you can see again, that number is getting bigger and bigger and bigger. And so with that, we need to be either increasing the volume of each breath, or we need to speed up the amount of breaths that we're taking to get even more of that carbon dioxide out. So in the state of Ohio, it's mandated that anytime you place an advanced airway, which includes any of the supraglottic airways like iGel, AirQ3, King Airway, et cetera, along with endotracheal intubation, that some sort of end tidal capnography is maintained on that person. So anybody that has one of those advanced airways in needs to stay on the monitor until they are on the hospital bed and getting ready to swap over to the hospital equipment. By keeping this person on, not only are we truly complying with the law, but that gives us pretty irrefutable proof that when we disconnected our equipment after they had been moved onto the hospital bed, that tube was in the right place, that it did not become dislodged during the movement, et cetera. So this is both protective for you as the provider, where sometimes we'll get accused of, well, that tube wasn't in the right spot. Well, look, the monitor shows that we were having good waveforms up until the moment that we disconnected. So it must have been you guys that dislodged it after that. So please, please, please make sure that you're keeping that person on end tidal. All right, so with advanced airways, we want to make sure that we have multiple breaths that are normal, and not just one or two breaths. And the reason for that is almost certainly someone listening right now is drinking some sort of carbonated beverage. That carbonation is carbon dioxide. So if we have been drinking a bunch of Diet Coke, and we intubate the esophagus, guess what we're going to get back? We're going to get back carbon dioxide because we've got carbon dioxide down in our stomach. Um, that number isn't being reproduced though. It's not like there's more carbon dioxide getting pushed into the stomach, with every breath. And so very rapidly that number and that graph will go down. It also is not going to look normal because it's not a normal exhalation. It's the stomach and the esophagus. So whenever we are using end-tidal capnography, et cetera, we need to make sure that we are doing this on multiple breaths and not just going with the first breath and, oh, hey, look, we've got carbon dioxide. We must be in the right spot. You need to make sure it's there for multiple breaths. And this is an example of that. It does not look like a normal waveform. It's kind of more of a hump shaped. And that number very rapidly goes down because no new carbon dioxide is being produced. This is just what was present there, and we've evacuated it now. Similarly, dislodged airways will have other funky waveforms. When we dislodge an airway, oftentimes that tip of the tube is just above those vocal cords, and so there still is gas exchange happening. We still are getting carbon dioxide into the endotracheal tube, but it's not a controlled system. It's not a closed loop. So we get these very funky waveforms that don't look like anything close to a normal wave. With COPD and asthma, that bronchospasm, et cetera, begins to cause trouble with moving gas. It becomes much more difficult to get the carbon dioxide out of the system. And so if we're having trouble getting things out of the system, it means that our graph is going to show that. If you remember nothing else from today's lecture, please remember this, that if you see shark fins on your end-tidal capnography, that you are giving this person more breathing treatments because it's an indication that this person needs more breathing treatments. So we see here, we already talked about asthma, so we're not going to belabor that. But with a COPD or asthmatic, we're going to see this more shark finned type appearance. And the reason is it's much harder for that gas to get out. And so we never really kind of get a plateau, as it were. It's more we get this slow climb to a peak. And this is, a demonstration of what a mild attack will look like. They're a little tachypnic, shark fin. As the attack worsens, their respiratory rate goes down because they're getting more and more tired, and their end-tidal capnography number is beginning to go up and up because they're just simply not able to exchange the gas very effectively anymore. This is a real world example where you can kind of see on this first. This is the classic shark fin. So this is what the person looked like on arrival, and after they started treatment, at 2 minutes later, you can already see that shark finning is beginning to improve. So we now have more of a plateau. It still very much looks like a shark fin, but it is far less, pronounced than the top one. And then after two breathing treatments, we're basically back to normal. We've got a very normal appearing wave now. So this means we don't need to give any more breathing treatments likely. So if you are using end-tidal capnography for your asthmatics, et cetera, and you're still seeing shark fins, it means you need more breathing treatments. If you're not seeing shark fins and your patient has improved, you probably don't need more breathing treatments because you've gotten that airway opened up enough. In cardiac arrest, we can also use capnography. Anybody who has called me for orders to cease efforts knows that one of the first things I'm going to ask you is what's their end-tidal capnography number, because that is very strongly correlated with success of resuscitation. If we've been resuscitating somebody for a half hour and their end-tidal capnography number is 10, they don't have any metabolism left. They're not producing carbon dioxide at that point. And so, really that's pretty indicative of they're dead. On the other hand, if we're 30 minutes in and we have an end tidal capnography number of 35, that means that our CPR has been pretty good, and they're actually still actively metabolizing things. It's not the sole determinant of whether we're going to continue the resuscitation or stop. But if this was a witnessed VFib, arrest that has remained in VFib and still has a good end tidal number, we better continue to work that, because we're perfusing them adequately, that they're producing carbon dioxide, and it was witnessed, so they hopefully got bystander CPR and their brain won't be damaged. Additionally, we can also tell, when rescuers switch. As you can see here, the end tidal capnography number is going down the longer and longer this person is doing compressions, and that's because they're getting tired. But then, as soon as they swap and get that, second rescuer in place, that person's fresh, so they're going to immediately begin to do much better, compressions than. The first person was. And so we'll see this big bump in end tidal because the perfusion all of a sudden got much better. Now, obviously, with the use of the Lucas device, et cetera, we don't really see this anymore. And that is one of the benefits of the Lucas device, is that it doesn't get tired. It's still able to do the same compressions as long as that battery is good. So we won't see this significant variability in the end tidal number. This is another example. We've got relatively low end tidal numbers, but then as soon as that other rescuer comes in, those numbers go up. This is another example of when we had ROSC. The heart is much better able to pump than we are on it. And so a really good indication of ROSC is when you have this big bump in the middle of your kind of time cycle. It may mean that at the next rhythm check that you're going to have pulses, because all of a sudden that heart kicked in and was able to pump even more blood, which cleaned out some of the peripheral CO2, et cetera, that had built up. This is another example. We've got cardiac arrest. Okay, we get ROSC, so we get this nice bump, and then, oh no, they arrested again, and then up, nice big bump, and oh no, they arrested again. But you can see how it can help predict at your next rhythm check what you're likely going to encounter. And this is another example: successful defibrillation. Their end tidal CO2 number goes up immediately because that heart is so much more efficient. Again, with ceasing efforts, I use it very strongly, but it's not the only determining factor in whether or not we continue with the resuscitation. If you're not perfusing well, which the end tidal tells us about how your perfusion is, then that does not bode well. We can also use end tidal for sepsis detection and resuscitation, similar to that cardiac arrest resuscitation, where, if we have a low perfusion state, like someone in septic shock, as their numbers begin to increase, as we improve their, perfusion, we should see that end tidal capnography number begin to go up, because we're now metabolizing and producing more carbon dioxide than we were before. We can also use end tidal capnography for sedation or altered mental status. I think it's virtually standard of care at this point that if you are giving somebody something that has the potential to depress their respiratory drive, such as pain meds, benzodiazepines, et cetera, that we really need to have them on end tidal capnography. It is a very cheap and effective, piece of equipment that can tell us about the adequacy of their breathing. Interestingly, there was a study done a few years ago that showed taking overdose victims and putting them on end tidal capnography while they were in the emergency department, and seeing whether or not the patients that were on end tidal had fewer adverse events. And I was very surprised by this. I think the authors were very surprised by this. But having them on end-tidal capnography in an emergency department setting did not protect them from any changes in the adverse events. With us, though, we're one-on-one, with our patients. It's not 5 or 7 on 1 like they are in the emergency department. And so um, we're better able to intervene and know right away when that capnography is becoming problematic. Head injuries, we really absolutely need to be using end-tidal capnography because we know that hyperventilation is bad. Hyperventilation constricts the cerebral blood vessels and reduces blood flow to the brain. If we're in danger of herniating, that's one thing. But I can count on one hand the number of times I've had somebody in the field that appeared to be actually actively herniating. Just because somebody has unequal pupils does not mean that they're herniating, especially if they're upright and talking to you. People getting ready to herniate do not talk. All right. Troubleshooting, basically, if you're kinked, it's not going to give you readings. If you're not completely seated well, it's not going to give you readings. I have heard of when the monitor is extremely cold. So if it was out in unheated ambulance bay for a while, it may take a little bit longer to warm up. And in the meantime, it may give you erroneous information until it's kind of warmed back up. All right. With that said, that brings us to the end. So thank you for attending. Again, my apologies about the initial connectivity issues. Hopefully, you guys were able to hear and see everything the rest of the time. I'll have to figure out the rest of today why I'm not able to get on the Wi-Fi here. So thank you, everybody. If I don't talk to you before the 4th, happy 4th of July. Stay safe, and we'll talk to you later.